Good day, all, and welcome to the Teledigm Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Well, Shane, we got some great guest on today. We're going to talk about some nephrology services and some of the exciting stuff he's been working on for us. So I will hand it off to you.
Great, thanks, Andy. I'm ecstatic to be here today with the esteemed Dr. Bryce Lund, and who heads up our Telenephrology program, which has been a significant cornerstone of the program for several years. And excited, Dr. Lund, to share a podcast with you and chat a little bit about you first and foremost, and then a little bit about the telenephrology program and various things to consider as you're contemplating a nephrology program, or perhaps some outpatient nephrology or dialysis center types of implications. And so excited to unpack that further. But without further ado, how about maybe an introduction of yourself and a little bit about yourself?
Absolutely. So, yeah, again, I'm Bryce Lund. I'm a nephrologist and have been practicing now for about 17 years, and do enjoy the telemedicine side of things. It's kind of got a newer feel to it, kind of helps you branch out a little bit into more areas. I finished up my training in 2007 and then started up nephrology practice, and I currently am working in Fremont, Nebraska, and I have some surrounding clinics, and then of course do a little bit of telemedicine as well, and also have a wife and 4 kids, and when I get a little free time, like to get outdoors.
Well, that's awesome. Well, speaking of outdoors, you just mentioned you were close to Andy's neck of the woods in Seward, and profiling how you're going to navigate the pole vaulting pit there in front of the local brewery on the 4th of July. So I'm just curious, number one, did you actually did you actually try that, or did you hold back and let the younger folks do that?
I held back, but I walked ever so slowly by just in case someone wanted to hand me a pole. But my wife kept moving basically, and nothing happened. And so eventually I had to walk away. But I was it was very interesting. I'm not a person who's watched much pole vaulting, and I don't think I was around it much when I was young, but have seen it on TV some. But yeah, mostly these college-age students were out there putting on a pretty good show, and that's a little something unique to see for 4th of July festivities.
Oh, without a doubt. I was shocked you mentioned that, but it's a unique offering to be pole vaulting in the middle of the street. So you kind of combine that with sitting in front of a brewery, and you kind of wonder how many craft beers does it take to figure out, you know what, I think I could do that. I think I could pole vault. So I'm glad that you did not attempt that. So I think that's good. Not that you couldn't have pulled it off.
Yeah. Well, maybe I'll go back next year. I'll just check back.
Yeah, I don't think that's a good idea. Yeah, let's stick to watching. How about that? Well, that sounds good. Hey, again, excited you're here today, Dr. Lund, and looking forward to talking to you today about telenephrology strategies and services. And you kind of mentioned you do a lot of our nephrology services, and which are located in a lot of large regional size hospitals, large hospitals, critical access hospitals, and a little bit of everything in between. But I'm interested in how, as you've been in private practice for years and in and out of hospitals for years, can you kind of describe your journey into virtual care and how it's kind of changed your perspective in practice?
Initially it started as we did outreach clinics, and oftentimes with those outreach clinics, whether or something comes up where it's difficult to get there, and that kind of leads to the question about the telemedicine visits. And then we had a few communities who wanted nephrologists. They're too small, of course, to have any regular clinic. And one way they can establish that is to get a nephrology clinic once a month or something, and doing it by telemedicine can make that work. Especially if they're long distance. We had a few of those that were maybe over an hour if it was drive time. So that helps out there. That kind of started up in the mid-teens where we did that with outreach clinics, and then of course that kind of transitioned into covering some hospitals. And once COVID hit, and I think telemedicine just had more encouragement at that time, and it's just continued to grow not only clinics but, like you say, hospitals, regional hospitals, all sorts.
And as your experience continues to grow on the virtual side of the equation and actually doing these telemedicine consults, which you've done hundreds of them, how does that change your perspective on your abilities to take care of patients and sort of parlay your resource capability across multiple facilities?
Oh, it's helped a lot. I mean, compared to maybe like early days where, things might have been trying to use iPads and FaceTime and some of the kind of platforms that aren't really medical, but they can get you by. The platform we have now is very nice. I mean, I'd say, kind of top of the line, lets you to really see and move the camera, see and use the stethoscope. Quite reliable. I think the personnel on the other end, the nurses, the staff, they feel fine. Just, they'll walk up to the cart right in the hallway and just say, hey, good morning, or they'll wave, and they'll just start talking to you just about like, you were there. So it's really implemented quite well. And I think patients accept it too, because they tend to get a quality experience. I mean, they have a screen that generally has a good resolution on it. There's no lag time. You feel like you're, pretty well connected when you're talking to them.
Yeah, that's great, and certainly appreciate that in terms of the orientation process, the set process for these programs to be successful. But it really does come back to putting quality physicians on the screen, such as yourself, and then that really perpetuates that patient and nurse satisfaction on the other end, without a doubt. So can completely appreciate that. In terms of the telenephrology service, I know that, I'll give you an example of one of the early programs that we launched was a 50-bed rural hospital that had, challenges with CKD patients that were in need of inpatient dialysis, or a routine dialysis run that maybe was admitted with pneumonia or needed a surgery but yet didn't have dialysis available. So they were transferring all those patients out or not electing to do those surgeries there. And we implemented this program as part of that strategy. And maybe you can talk a little bit about how that, let's stick to the routine stuff for now, but more of that routine inpatient dialysis, how that comes together and how does that work, and how do you relate and work with the dialysis nurse on that front?
Right. Well, for those dialysis patients that have been getting treatments routinely, not too much has to change when they come into the hospital. So it's pretty straightforward to work out. At the hospital side of things, of course, they would let telenephrology know about the patient. There's a dialysis nurse that I would usually connect with as well. And of course, there's some back end issues. Consider you get a hold of the unit where they're getting dialysis treatments. You find out information about their treatments with, time and lab tests that have been done, and kind of weights and fluid goals that you're going for. So you get all that, and of course, based off whatever testing they've had done in the hospital, it's pretty straightforward to get their dialysis treatment in. Again, they got the dialysis nurse that can help take care of that in addition to the floor nurse. And I'd say it's pretty straightforward to get that accomplished, and they can stay at the hospital then and continue to have whatever they need, their orthopedic surgery or recover from their pneumonia. And then, of course, when they're done, they're discharged and go back to their dialysis unit.
Yeah, I think that's spectacular. And the other piece that's been sort of a welcoming or a refreshing component to the telenephrology program is the improvement, or at a minimum, the increase in the accessibility and sort of efficiency on the telenephrology programs, or the actual, no, that's not correct, it's not telenephrology programs, but the actual device and unit you use to do the dialysis runs is more conducive to remote types of situations versus the back in the day where you had to sort of have a 4 plumbers and electrician and all kinds of modifications to bricks and mortar buildings to run those runs, right?
Oh, very true. One of the facilities we're working with now, they have been using Tableau dialysis machines, which is kind of what you might be describing. Back in the day, the original dialysis machine, you kind of had a really large dialysis machine that was almost up to your shoulder that just did the treatment. And then you had a secondary water processing machine that was about a little higher than your knee. And both of them were a little technical to run and get to run together, and had to have the right kind of plugins and plumbing and all this. But as we use these Tableau machines, they're kind of all in one. They're much easier to use. They only come up about to your waist, smaller, handier, also easier interface with kind of the buttons, and nurses enjoy that as well. So you can basically roll this one machine into the room. Basically, as long as you have kind of a standard water hookup and drain, you're pretty much good to go. And so it doesn't take quite as much of the technical expertise, if you will, for like a water technician or other technician for the machine. So it helps out those smaller communities, hospitals that don't want to quite invest into all this infrastructure or personnel to get that done.
Sure. And then in terms of from your experience in managing these types of patients virtually for as long as you have, can you kind of describe the feedback you get from the nurses that are operating the systems in terms of the complexity of use? I mean, from what I'm told, most of the nursing staff that is operating these systems has quite a bit of confidence, and it seems to be pretty user friendly. Would you agree with that?
I would agree. Yeah. Again, kind of citing the hospital where we're using the Tableau machines. Of course, they keep a couple of them, one for kind of a backup. And not too often you need a backup. So typically you're always doing well with the one machine, and maybe about once or twice a year there's some kind of issue where the one needs to be reset and you rely on the backup machine. But the nurses feel real good about that. And again, this Tableau dialysis machine that we use, the company will provide service to that. So if you're in a little bit of a bind with some error code or some question about how it works, you can call the company and they're almost immediately responsive. They'll even have technicians stop out if need be, even same day. So it does work quite well with that, and the dialysis nurses seem to be quite happy with it. Easier to kind of provide the treatments, which anything that makes hospital stays easier is generally a pretty nice deal. So yeah, that works well. Floor nurses like it as well. They kind of understand and can read the screens a little bit better as well. So all in all, yeah, a nice progress and a good machine for kind of small to mid-sized hospitals.
That's perfect. And for what it's worth, I'll tell you who's very appreciative is the patients who can stay locally rather than having to be transferred just for a CKD run. So I think it's the service and the value proposition you add is fantastic, and the patients out there definitely appreciate it. Now, how about if you're considering starting an inpatient nephrology program, let's take for maybe you're a smaller hospital or maybe even a larger regional hospital, and maybe you haven't done a lot on the dialysis front. Perhaps you don't even have any sort of inpatient dialysis activity or Tableau machines or whatever. What are some of the considerations what would be sort of the top 3, 4, 5 things you should think about in terms of strategy on building an inpatient nephrology program?
Well, the kind of the straightforward thing might be the equipment. I mean, like I mentioned, the machines that you use now are pretty straightforward, easier to use. And basically, if you get 2 machines, you pretty much can do about as many treatments as you need to. The more challenging aspect would be the staffing, the personnel. But I would say probably most small to medium-sized hospitals, if you're doing under 30 or 50 treatments a month, you probably can get by with 2 dialysis nurses that basically rotate some sort of call schedule or shift. So I guess that's what I'd be thinking about is, at least 2 machines, at least 2 nurses, maybe with a third backup. And then the hospital most likely is going to have some of the technicians that help watch over some of the oh, you have to check the cultures on the machines and for bacteria, and basically the water needs to test correctly. But there's labs that you can send that out to, and the hospitals generally have the technicians who know how to do all that. So not too hard from that standpoint.
Well, I think that's great. And in terms of the dialysis nurses, so we've had scenarios where the hospitals partnered with nurses that are private practice, not private practice nurses, but they work for an outside entity. Maybe perhaps they're coming from a dialysis center. So they're a dialysis nurse that works for the dialysis center in that particular community or in a nearby community who then migrates to the hospital to just do the dialysis run. Can you speak to some of that?
Yeah, that does happen, and in fact, that's a nice resource. And uh, dialysis units, kind of mid-size towns or cities, anytime you have a dialysis unit, they're going to have several nurses that might be able to kind of cross cover in the right condition. I also find it's not uncommon when you're in the hospital, some of the floor nurses will just tell you, oh, yeah, I used to work in a dialysis unit. I know in our hospital, we had two of those, and basically we kind of maybe just refreshed their training and they were good to go. We even had a floor nurse who just got trained there because we already had, a couple nurses, but one was moving on. So we just trained a new one under the old nurses to kind of fill the gap. So there's a few ways to kind of cover that, but dialysis units are a good way to kind of look for some of those resources.
That's great. I know that there's been some experiences where the nurses sort of trained just on tablet. They haven't really done a whole lot of dialysis work in the past, but the equipment lends itself to somebody who wants to sort of dive in and learn how to do that to make it much easier rather than it was several years ago.
Yeah, the equipment is much easier, and I would say kind of training on the equipment maybe is only half of the concern. The Probably the other equal half of it is kind of getting them used to cannulating or putting the needles in for the fistulas for the dialysis treatment, which really is just a matter of kind of experience and time. But if you already have one nurse who's worked at a dialysis unit, she kind of is able to bring that with her, and then if there's someone else on the floor, they can kind of oversee and train a little bit. So it's a little of both, but the machine, I think, is probably not so much the limiting factor as kind of the training on how to do the access with the cannulations, and a little bit the catheters that are used too.
Well, no, that's definitely a huge value add to the community and a great service for the community.
Well, I was just going to maybe expand on that a little bit. There are these hospitals that probably don't have a nephrologist, at least nearby. And one way they can kind of test the waters, I think, is looking at maybe telenephrology, just starting, looking at just doing cases, non-dialysis, and having them see patients in the hospital, telenephrology, you kind of get a sense of how many needs there is. And I would guess once you kind of have the nephrologist see a few patients, you get an idea of how many you might capture that might need dialysis. And if you have somewhere around, I would say if you would expect like 20 plus treatments a month, probably would be in the interest of the hospital of trying to make that happen with the program. A rough estimate, but that might help some hospitals kind of get into that, just first starting with regular consults and then seeing about dialysis.
Yeah, absolutely. I can't agree more. And the other piece of that too is in a lot of situations, we hear from surgeons that are doing certain operative procedures that would like to have nephrology available in the event they come out of surgery and they have a low sodium issue, and then there's something that maybe they didn't quite pick off, or perhaps there's another patient where their creatinine's ballooning, and they have some other things that are indicative of an ongoing nephrology, or perhaps a new diagnosis potentially that nephrology could definitely help weigh in on. Absolutely, so completely agree with that for sure. Which, by the way, in all instances, when we do run those programs, the nephrology team is available for any of the routine nephrology consultations in addition to the dialysis runs for sure, and can be available as well for more ICU related activities. communities as it relates to nephrology as well, although that's relatively rare anymore, but nonetheless is a possibility and availability for that as well. In addition to that, we've had scenarios where we've augmented schedules where perhaps they have a nephrologist locally that's working maybe a third of the month and we cover 2/3 of the month, or vice versa. It's a great recruitment. It's a great recruitment tool, and it's a great ongoing physician satisfier to keep that physician in those communities that may struggle to get 2 or 3 nephrologists to come to their community. So it's a great consideration for that. Let's talk a little bit to kind of close things up as folks are thinking about whether you've already mentioned kind of the outpatient side of the equation, but beyond outpatient, what are things to consider if you're contemplating getting into opening more of an outpatient dialysis center of some type? And what are some considerations you would consider on that front, which are maybe a little bit different or maybe a lot of bit different than the inpatient side? What are your thoughts on that?
Yeah, yeah. So on the outpatient side, that definitely takes more development and I guess training to get that done. I think you'd want to start out researching a little bit about how many dialysis patients are in the community. And there are ways to kind of look into that, by Medicare records, and you can get a sense. But essentially, dialysis units are, you would say, a little more difficult to run the smaller they are. So if it's able were to start where you have maybe about 20-25 patients at a minimum, that'd probably be a starting area where it might be worth it to do an outpatient dialysis unit. But there's a lot to think about there. Again, there's the staffing. Of course, you need nurses, kind of a center coordinator. They usually have some patient care techs that help out the nurses, maybe in a ratio of 2 techs to 1 nurse or 3 techs to 1 nurse, something like that. But probably the big thing is that dialysis units, the real difficulty is in their water systems. In that when the building is built, you need essentially a plumbing system that provides water to every dialysis chair, if you will. So it tends to get a little complex building the plumbing system and all the filters and lots of stuff, carbon filters, particle filters. There's even some irradiation. So a little complex. And, if you got to that point, you'd probably go check out other places that have done that before so you could get a little idea of how to go about doing that. But I would say a lot of this depends on your community and first finding out how many dialysis patients in the community. And again, if kind of above that 20-25 mark, that would probably be where you'd start looking at it.
And in terms of things like medical direction for those types of services or providing virtual physician consults into those facilities, I know you've had some experience with that. Can you maybe speak a little bit about some of the experiences with medical direction for those facilities and the ability to do that remotely?
Yes, yes. So the dialysis units, part of the Medicare guidelines is that they do require a medical director. So the unit needs a physician to essentially watch over basically everything that's done, from the protocols for what nurses do to respond to emergencies, to the protocols that are done to make sure you have quality water and have quality outcomes for patients. So every dialysis unit needs that, and there's some forms and procedures to go off of to get that accomplished, so you don't have to start from scratch. But all that needs to be monitored, and so a medical director does that. And typically, that director needs to go out to the unit, at least once a month, maybe more often if possible. But a lot of that can be done remotely too, where you could call in or possibly have something like a video conference or some sort of meeting that you could review a lot without being there.
Well, that's awesome, and I really appreciate your time today, Dr. Lund. And is there anything else that you can think of that you'd like to cover at this point in time?
Yeah, well, I would just say it's that telenephrology is, fairly enjoyable. Even though you might think, well, that's pretty technical and using the screens, I'd have to say that the amount of times I've done it, patients seem to just really enjoy that more than you might expect. And part of that I kind of compare to like when you walk into the patient's room, it's a little bit of maybe they're thinking that, you're there, you're in the hospital, that's all kind of standard. But when you're kind of bringing in someone else from kind of out of the system, and they just seem to have a general, a little more sense of appreciation. And it's remarkable how often they will say, well, appreciate you checking on me, or thank you. And, they're even interested where you're from, and, and you tend to have pretty good conversations with that. So I again, we all like to be there in person, and folks like to, see the doctor from time to time, but they certainly appreciate this, and it's still a nice personal connection.
I can't agree more. And, again, to augment that, the patients really are, they basically, they connect the dots, right? They connect us. Since Dr. Lund was able to see me here, I don't have to be transferred. And man, that's a huge, huge, huge burden lifted from those patients and those families that don't have to transfer those patients to a different facility, for sure.
Oh, I'd agree. And, it's even remarkable after you've kind of been involved with it for a bit. I mean, you start seeing patients that you've seen before. And, the nurse, you call up, the nurse, of course, takes your cart in the room, and, there's the patient, and, hey, Mrs. Jones, I'm Dr. Lund, and, I help out with dialysis and these other issues. And she'll say, oh, yeah, I remember you from last time. And it's like, well, great. And, it actually goes quite smoothly, and it works very similar to, the old fashioned way of just being up in the hospital.
Well, that's spectacular. And I can't thank you enough, number one, for spending your time today. And then number two, for all the great work you're doing in and around Nebraska, and for the facilities and helping to keep patients closer to home via Telenephrology and our virtual care services program. So I really do appreciate your time today, and it's great information for our prospective individuals and current individuals out there that are partners of ours, and looking forward to expand services. So really do appreciate your time today, Dr. Lund, and looking forward to seeing you in person here soon, okay?
You bet. Thank you, Shane.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledigmhealth.com.